we're presenting the CPC, and I did want to introduce, well, David Salmon helped a lot with this, and he'll be providing input. And then Allison is, Allison might get this wrong, I think a cognitive neurology fellow who did neurology residency previously and is interested particularly in dementias and especially posterior cortical atrophy, which is what we'll be talking about. Melanie is the first year neuropathology fellow. She did a forensics fellowship at the San Diego Medical Examiner and is now doing neuropath and is, I'm hoping to, she's going to work with us on some neurodegenerative research next year. So I'm going to let these guys get started and then I'll hop in as needed. Okay, Allison, take it away.
Okay, great. So these are ADRC patients who we did not personally care for. And so we're going to talk about two cases and kind of a comparison between the two. So we'll get started with the clinical history for the first case. This is a 56-year-old right-handed woman who developed problems with vision, particularly with reading. And 3 years after the onset of her symptoms, she was seen by a neuro-ophthalmologist and was referred to neurology. And by the time that she had this evaluation, she was having trouble processing information and sometimes was unable to identify objects. And she also was having difficulty with math. And she was seen at the ADRC the following year, so about 4 years after symptom onset. And at this point, she was still independent in her IADLs, except she was needing some help with finances. And she was listening to books on tape, recalling well what she listened to, having normal conversations, and retaining information from those well also, following current events, managing her own appointments, and she was traveling alone quite a lot by train and not having any issues with that. She was starting to have some trouble with recognizing people. And over time, she had worsening visual abilities, and this had an increasing impact on her function, and she had increased forgetfulness over time as well. And she continued to have worsening calculation and language abilities too. And over time, she became completely blind. So she was relatively healthy in terms of her other medical problems. She had osteoarthritis, prediabetes, anxiety, and then she developed some auditory hallucinations. And in terms of her risk factors for dementia, she had a maternal aunt with dementia that started at age 74 and was not exactly clear what type of dementia. And then for medication, she was taking Risperdal, a multivitamin, and some other vitamins and supplements. So on her first exam, so this was 4 years after her symptom onset, the patient was fully oriented. Her remote memory was intact. She did make an error with calculations, and she was able to follow complex commands correctly, and her recall was pretty good. She was able to recall 4 out of 5 parts of a name and address. And then her language was normal, except for when she was reading a command, but verbal language was completely normal. Fluency was normal. And then she had some pretty significant issues with construction. So with figure construction, clock construction, picture interpretation. And then she also had a major error with her recall of figure construction. And then her general neurologic exam, including her vision, was normal. So here's an example of copying these figures, and you can see there's pretty significant errors here. And then at this initial exam, her MMSE was 29 out of 30. And the only point that she missed was copying pentagons, where there was some pretty significant errors. And then over time in clinic, she had these serial MOCAs done, and there was a decline over time. So other studies that she had completed, she had an EEG that did not show any epileptiform abnormalities. It just showed some mild nonspecific findings. And then she had an MRI of her brain that showed occipital greater than global atrophy, and no other findings that would potentially explain vision loss. So no, strokes or anything focal in the areas that could affect her vision. And then on repeat MRI, she still had atrophy and some white matter disease, but again, nothing, no structural abnormalities, no unexpected structural abnormalities besides the atrophy. And she had a spinal tap done, and her CSF for the basic studies was normal. She had 1 red blood cell, 1 white blood cell, glucose of 53, protein of 22, and she had biomarkers sent for tau and A beta. And these showed a pattern consistent with Alzheimer's disease. So she had an elevated tau and a low A beta. Tau was 859, A beta was 300. And then she also had genotyping done through the ADRC, and she was ApoE23. So here's a picture of her MRI, and she had some global atrophy and then a bit more posterior atrophy, the parietal and occipital areas. And here too, you can see that there's just a bit more atrophy in the posterior areas. And then on her coronals, the temporal lobes are not atrophic out of proportion to the rest of the brain, and her hippocampi, you can see in the middle slide, actually look pretty good. So there's no disproportionate atrophy in those areas. So I'm just going to give one kind of intro slide about PCA, and then we can talk about the pathology. So PCA is a neurodegenerative syndrome that primarily affects the parietal and occipital lobes. And the most common underlying pathology is Alzheimer's disease, but PCA can also be caused by corticobasal degeneration, Lewy body disease, and rarely prion disease. And patients tend to have a very early age at disease onset. So the average age at presentation is 50 to 65 years. And as with other kinds of early onset Alzheimer's disease, a lot of times these patients get misdiagnosed for periods of time. So sort of like this patient who 3 years after her symptom onset still did not have a clear diagnosis. And so the core features are visuospatial and perceptual deficits.
Thanks, Allison. And now on to growth. So I'd like to start with, for everybody that is examined at the ADRC or the Alzheimer's Disease Research Center, they do have a very detailed report on the histology and the gross examination, as well as this form. So the Neuropathology data form that's provided by NAC, which stands for the National Alzheimer's Coordinating Center. So all the data from this form gets loaded into a national and searchable database. So you can imagine that would be an amazing tool for research. And I also thought it would be a good tool to go through the gross findings using this form to go along with our case. So one of the things you look for is weight. It's the fixed weight. So it's also calculated because we receive half of the brain. So calculated weight is 1070, which is a little bit light. Expected weight for female and age is about 1150 to 1400 grams. So this can kind of give you an idea that there's some, even before looking at the brain, that some atrophy is going on. So in terms of atrophy, we look for generalized, so like cerebral cortex atrophy, and then we also comment on lobar atrophy, specifically if it's in the frontal and or temporal lobes. So this is case 1. This is the lateral view of the left hemibrain. Similar to the MR findings, there is moderate diffuse cortical atrophy, mostly based on the weight. So, and then for lobar, so frontal, there's minimal atrophy, and in the temporal lobe, you can see that there's relative sparing. And then, so we checked those off, and I did put an asterisk next to this lobar atrophy. So similar to the MRI findings, we did see that there is pronounced atrophy exclusively in the occipital lobe. And then another indication that we look for to suggest that there's atrophy if the ventricles are enlarged. So a way that we can do that, because it can be subjective, but a good landmark here, the blue arrow showing the tip of the temporal lobe. And that's, so if you have the ventricle extending anterior to that, that's a good idea that your ventricles are somewhat enlarged. And then also you can have hydrocephalus ex vacuo. So the appearance that when you have atrophy, that there appears to be an increase in CSF, but it's actually the pressure remains the same. So moving along, we also comment on if there's atrophy in the hippocampus. Our case is unremarkable. So I put another asterisk there because what's remarkable is that it's unremarkable. So typically the progression of pathology seen in Alzheimer's disease, it'll start in the hippocampus. So. And then other areas we look for are pigmentation in the substantia nigra and the locus coeruleus. So the neurons in those areas contain neuromelanin. So when you see hypopigmentation, that gives you an idea that you have some neurodegenerative process going on in that area. So our case here, grossly, the substantia nigra is normally pigmented. In the locus coeruleus, it's a little challenging to pick that out, but it is severely depigmentated. There's lack of pigment, hypopigmentation. And lastly, we also comment on atherosclerosis, because another cause of neurodegeneration is if you have vascular problems, strokes, so forth. So then highlighting the features that go along with posterior cortical atrophy, I did put examples side by side so that can demonstrate that for you. So on the left here, this is a brain history of a typical presentation of Alzheimer's, and you can see that this is diffuse atrophy. And then here again on the right, you see this more pronounced occipital atrophy out of proportion to frontal and temporal. And here's a better look at that occipital atrophy. And again, commenting on the normal hippocampus in our case. And here on the left is an example of what it looks like when it's severely atrophic. Now going on to the histology. So again, I'm just going broad again. So I think it's important to talk about the idea of protein misfolding in neurodegenerative diseases in general. So depending on the clinical, so here on the left here, as you walk through this diagram, is your clinical diagnosis. And for all of these diseases, specific proteins have been identified as the bad actors. These proteins, they undergo abnormal misfolding and aggregate, and that's what causes the neurodegeneration. And that kind of guides us what stains we use and what we look for. So these are the 4 stains that we use at the ADRC. So the first 2 are specifically for Alzheimer's. So the tau antibody we look for, as you can see here on the right, we look for tau tangles and neuritic plaques. amyloid beta, we look for amyloid plaques or senile or diffuse plaques. We also look for non-Alzheimer's disease pathology. And so we use alpha-synuclein to look for Lewy body pathologies, for example, in Parkinson's. And we also do TDP43, so another protein that has roles in several other neurodegenerative disorders, including Alzheimer's. So again, I'm going broad again because the grading score can get a little bit complicated. So the end goal will be to have this, what we call the Alzheimer's disease neuropathologic changes. So basically it's a hybrid of 3 scores, which I will go through later. And it comes out with a score of low, intermediate, or high. And then what's important to note here from this slide is intermediate or high neuropathologic change is considered sufficient explanation for dementia. So first test that I'm going to go through is the Thal phase, in which we use the amyloid beta stain to assess for plaque burden. And so this is a little bit of a busy slide, but just to indicate here, the red boxes on the left, those are the blocks that we sampled for this case. And to give you an idea that there are a lot of studies been done that have shown that the disease process happens sequentially throughout the brain in a somewhat predictable manner. So, and then with that being in mind, they are assigned a grade. And so I will go through the histo now. So we do see, this is amyloid beta. So we see these plaques on the right. Left here is the H&E. And you can almost make out, so the areas where there's less cellularity, they're kind of hard to see because they actually are kind of hard to see, the plaques here and how nicely the stain helps. So this is middle frontal gyrus. So that would be phase 1. Another good thing about the amyloid beta stain is that you can look for amyloid angiopathy. So the blue arrow picking up here, this staining of amyloid in this vessel. Then in the entorhinal cortex, there are several plaques. That would be a 2. We also have them in the basal ganglia, which would be a 3, and so forth. So here it's interesting. So in the substantia nigra, you can see here you have that neuromelanin pigment in the neurons, but you also have the diffuse plaques. And in the cerebellum, you can see them here. They look, interestingly enough, they do look a little bit different when they're in the cerebellum. They're a bit smudgy. And again, noting that there's some amyloid angiopathy. So that gets us up to a Thal phase 5, which gives us a score of a 3. So the next test would be Brock stage. So we use the tau stain to assess neurofibrillar tangle burden. So here, this is a bit of a busy slide, but again, lots of studies have done on disease progression and for where the pathology starts and how it progresses. And so here, I'll show you up close. So as I mentioned, usually the beginning affects the entorhinal cortex and hippocampus. And you can see with each stage that this darkening highlights where the tangles are. And so in our stage, in our case, we have these tangles pretty much everywhere. So the entorhinal cortex, superior temporal gyrus, which pitches up always already to a stage 5, mental frontal gyrus, and the occipital lobe. So that gets us to a stage 6, and with a score of B3. And so interestingly enough, so for the Brock staging, they really account for if the tangles are present. They don't really account for the density of the tangles, but the interesting point of this case is that at the low power, you can really see the difference in density. So here, it's very dense in the occipital lobe, moderately dense in the middle frontal, and in the entorhinal cortex, it's much less. So that will be a topic of discussion later on in the presentation with our kind of future ideas for studies. So, and then the last part of the hybrid score is the CRAD score, which stands for Consortium to Establish a Registry for Alzheimer's Disease. So, so this takes into account the density of neuritic plaque burden. So here again, so we look for tangles and plaques, and then we're graded on sparse, moderate to frequent. And in our case, it was considered moderate, so giving a score of C2. So now going back to that slide that I showed at the beginning. So if we have a Thal score of a 3 and a CRAD score of a 3, that will give us a high ADNC score. So that's kind of where that comes from. And again, reiterating, and so it's always important to study other causes of dementia. So if you're evaluating the brain, you want to make sure that we're, see if all of the clinical symptoms are not from other non-AD pathologies. So we do look for neuron loss in the substantia nigra. So ours were well preserved. And then TDP 43 was negative. I apologize, the stain was quite faded, but this is the dentate gyrus, which is negative. So in summary, a case 1 diagnosis. So it'd be a high ADNC, Thal phase 5, score A3, Brock stage 6, score B3, and a CRAD of C2. And then we do also comment that there is amyloid angiopathy, and we did see a microscopic remote infarct. And so, the combined gross and histopathologic findings are, so it's including the relative sparing of the hippocampus, extent of involvement of the occipital lobe, out of proportion to the middle and temporal lobes. That this is an atypical presentation for Alzheimer's disease and is most consistent with posterior cerebral atrophy. And now back to Allison for more clinical information on PCA.
Okay, thanks. In terms of the clinical presentation, there's generally an insidious onset and a gradual progression. And patients tend to have prominent early disturbance of visual abilities with or without other posterior cognitive functions. And this is, a higher order visual issue that's not actually visual acuity. And in terms of cognitive features, patients need to have at least 3 of these in order to meet criteria early on in the disease course. And the ones highlighted in purple are part of the Lynch syndrome. And it's rare to have a pure presentation of this, but there's often features of this and then also features of Gerstmann syndrome, which are highlighted in blue. So simultagnosia is difficulty perceiving more than one object at a time. And this can be tested by seeing if somebody is able to interpret the entirety of a picture rather than just pointing out individual features. And then patients can also have oculomotor apraxia, and this is difficulty shifting gaze to what you want to look at. And then there can also be optic ataxia, and this is trouble coordinating visual movements with motor movements. So for example, looking at something and being able to reach for it. And then the aspects of Gerstmann syndrome include left-right disorientation, acalcula, agraphia, and finger agnosia. And then other features that can be present, there can be a space perception deficit. There can be a object perception deficit. There can be constructional dyspraxia, as we saw with the figure copy earlier, and environmental agnosia. So for example, having trouble recognizing a familiar area. And then patients can also have dressing apraxia, alexia, limb apraxia, aperceptive prosopagnosia, and a homonymous field deficit. And that deficit typically doesn't follow an expected deficit for someone who had something like a stroke. It would be more of an unusual field deficit. And so in terms of inclusion and exclusion criteria, so patients with PCA early on have relative sparing of other domains of cognition. So they'll be relatively spared anterograde memory, non-visual language functions, executive functions, and relatively spared behavior and personality as well. And then it's important to exclude other causes besides a neurodegenerative condition. So, to make sure that there's not some type of tumor or stroke that could be causing the symptoms, and then also ruling out any primary visual cause. So for example, a problem with the optic nerve, to make sure that it's actually a problem with the brain that's causing the symptoms. And then ruling out any other causes for cognitive impairment, like general medical causes. And so here's a way to kind of go through and think about the diagnosis. So first, seeing if the condition does seem to be neurodegenerative, and then if patients meet criteria for PCA. And then you can determine if it's PCA pure, where patients really just meet criteria for PCA only, or whether they meet criteria for some other type of neurodegenerative syndrome as well. And then you can see what the underlying disease process is. So as I mentioned, for PCA pure and plus, in order to have PCA, you need to fulfill criteria for PCA. And then to see if someone has PCA plus, you see if they also fulfill criteria for something else as well. So like Lewy body disease or CBD. And then diagnosing at a disease level. So the only one that actually can be confirmed while patients are still alive is PCA AD. And this is patients who fulfill PCA criteria and then also have evidence of AD pathology. And so patients can have, like our patient from case 1, you can have a CSF that's with low A beta or increased tau that's suggestive of Alzheimer's disease. You can have a positive amyloid PET scan. And then patients can also be diagnosed if they have a autosomal dominant mutation. So like presenilin 1, presenilin 2, or APP. And then for diagnosing PCA, Lewy body disease, PCA due to CBD or prion disease, it's only probable until you can confirm the diagnosis with pathology. Probable PCA Lewy body disease can be diagnosed if patients meet criteria and if their AD biomarkers are negative. And then again, to have an actual confirmation, you need pathology. And then for PCA CBD, same thing. If patient meets clinical criteria and are AD biomarker negative, and then confirmed by autopsy, and prion disease is confirmed by autopsy as well. So in terms of evaluating a patient for PCA, so we went through, history taking and the neurologic exam. And additional tests that can be helpful are visual field testing. So again, visual acuity is not affected. And visual field testing often shows constriction and potentially some unusual patterns, and patients can even be suspected of having something that's not organic. And for neuropsych testing, sometimes this can be a little bit difficult, particularly as visual deficits get worse, and it can become hard to test other domains. So sometimes information may need to be presented verbally rather than like typical visual tests that may be used to test, features of cognition other than just visuospatial. And so patients have deficits in parietal tasks. So there's often problems with object perception, space perception, calculation, spelling, and there's a relative preservation of memory and executive tests, particularly early on in the course of the disease. And for structural imaging, there's often volume loss in the posterior brain regions, and patients don't always have an expected pattern of atrophy. So PCA definitely cannot be ruled out if somebody has a normal MRI without this posterior atrophy. And then functional imaging is a little bit more sensitive and more likely to be seen earlier on. And FDG PET can show hypometabolism in the parieto-occipital cortices, and then ASL on MRI can also be affected. So you can see decreased blood flow to those posterior areas. And for molecular imaging, amyloid PET scans are often positive if there is an underlying Alzheimer's diagnosis, but this does not look any different from a positive amyloid PET scan from typical Alzheimer's disease. And then tau deposition is focal and does differentiate PCA. However, it's not available clinically. And I've already mentioned the CSF findings. So if it's due to Alzheimer's disease, then there'll be the expected findings with low A beta and increased tau. And in PCA, tau may not be as elevated as in typical AD. So here's an example of some of the imaging findings. So this control on the left shows normal imaging, and then these are some PCA patient examples. And there is decreased blood flow in the PCA patients on ASL. And then there's also decreased glucose metabolism in the posterior regions. And there's some MRI atrophy, but it's not really extreme in all of these cases. And there's some increased amyloid deposition, and you can see that it's more diffuse. It doesn't have any particular pattern that's specific to PCA. And then in terms of the typical cognitive features of Alzheimer's versus PCA, this is just showing which areas tend to be more affected. And the smaller the colored sections are, the more impaired a area is. So for typical Alzheimer's disease, nonverbal memory and verbal memory are very impaired. And then you can see for PCA, these more visuospatial areas in the bottom portion are more impaired. And we're going to talk a bit about typical Alzheimer's disease and how there can sometimes be a pattern of more visuospatial impairment, even in patients who, also have this verbal and nonverbal memory. And this often happens in patients with earlier onset. The next slide shows a histogram, and it's showing the age of onset of PCA, which is much younger than in typical AD, and you're more likely to see these unusual, not just amnestic deficits. So case 2 is an example that that kind of highlights this spectrum. So case 2 is a 58-year-old woman who presented with a 4-year history of cognitive decline. And her problem started with difficulty with organization, for example, organizing phone bills, which she used to pay. And then she was also having trouble with puzzles and arranging items in her home. And her family also noticed that she was having forgetfulness early on as well, which is different from our first patient that we talked about, where memory wasn't affected until much later. And 2 years after onset, she was having trouble with writing and spelling and stopped doing crossword puzzles. And her husband had to take over the finances. And then several years later, she was having some trouble with word finding and finishing sentences and was having increased confusion. And she became dependent in IADLs and ADLs and needed help with dressing and food preparation, and was having trouble cooking and was no longer able to play solitaire. So she doesn't have any really significant past medical or relevant family history. And on her initial exam, she was not oriented to the day of the month. She did have remote memory impairment, had an error with calculation. And this is an important difference from the first case where she only recalled 1 out of 5 parts of a name and address. And for language, she had abnormal fluency, impaired naming, impaired repetition, difficulty reading and following commands, and an inability to write a complete sentence. And in terms of fluency, it was decreased with only 7 names in 60 seconds. And figure copy was also impaired. We can look at that in a moment. And her general neurologic exam was normal. So here there were significant difficulties with figure copy, but she was having memory and other significant deficits already as well. And so this is a comparison of 3 different patients. The one on the far right is the first case, the pure PCA patient who we discussed. And that patient had severe visuospatial and memory deficits with everything else relatively preserved. And then
Allison, can I jump in 1 second?
Oh, please, yeah.
No, I just wanted to let people know, I'm sorry, the legend got cut off, so you might not be able to tell which bar goes with which. But if you go from top to bottom, attention down to visuospatial, it corresponds to left to right on the bars. So the very first bar, the black bar, is attention. And the next bar is verbal memory, and so on. So the last bar in each patient is visuospatial deficits. So sorry about that.
Oh, no, thank you.
Ahead.
That helped make a lot more sense. So thank you.
Yeah. So
I should probably, so for this first patient, we're looking at the very farthest bar to the right, and you can see that visuospatial is very impaired. And then for the PCA plus patient, this patient also had visuospatial deficits, but had other significant deficits as well. So problems with verbal memory and visual memory and language and attention. So seeing kind of the deficits you would see with a typical AD patient, but then a bit more impairment than you would expect for visuospatial. And then in the typical AD patient, there was the most impairment in memory, and then these other domains are relatively mild compared to that.
And back to neuropathology. And so unfortunately, we don't have any gross pictures of this case, but I will again use that the neuropathology data form. So this brain weighed, calculated weight was 898, so very significantly atrophic by weight. We did see moderate cerebral cortex atrophy, and again, similar to the previous case, we did not see any significant frontal or temporal atrophy. Again, like the other case, there was hippocampal sparing. And also similarly, the substantia nigra was not hypopigmented, and the locus coeruleus was severely hypopigmented, and there was mild atherosclerosis of the circle Willis. And for histology, so in terms of, this exam was done in 2011 prior to kind of using the Thal stage phasing. So, and also the stain. So they, and in this case, a thioflavin S preparation was used. So you can see the, will highlight the senile plaques or the diffuse plaques, but the sections were also limited to the cortex. So based on the report, we could say this case was at least a Thal phase 3, but probably likely even higher than that. And in terms of the Brock staging, that was considered a stage 6. And CRAD, so this was, the previous case was a C2, and this one was considered frequent neuritic plaques, which is a C3. So again, going back to that table that will give us the ADNC score. So here, for A is either 2 or 3 with any CRAD level, which gives us an intermediate score but at a minimum, but it was more probably high. And so, so in terms of the pathology, so this case did have clinical features that overlapped with PCA and some pathology findings, but however, the occipital lobe was not evaluated in this case. And now Dr. Hiniker is going to go into about future research possibilities at the ADRC and looking into cases with posterior cerebral atrophy.
Sorry, can you see my screen now and hear me? Yeah, Melanie, great.
Yeah.
Okay, so the reason I wanted to present these two cases is because they raise something that Doug Galasco and David Salmon and Dennis Smirnov, and now we've roped in Allison and Melanie to work on this, have gotten really interested in. So here I'm showing you the first case. This is the standard PCA case, and it shows you that, hopefully, can you see my arrow? The occipital lobe, right, is densely packed with tau pathology and neurofibrillary tangles. The entorhinal cortex is much, much more sparsely affected. And this isn't a surprise. This is published and this is known. So there was a paper from 2004 just showing exactly this, that PCA cases show disproportionate tau pathology in the occipital lobe, with kind of sparing of the entorhinal cortex and hippocampus, but really strong, extensive, and here they're counting neurofibrillary tangles, tau pathology in occipital lobe, particularly visual cortical areas. And so, and then I should say that this paper also showed that amyloid pathology is much more like broadly distributed throughout the brain. And it really seems like it's the tau pathology that is clustered in the occipital lobe. So this made us think about cases like case 2, where we see cases that aren't clinically diagnosed as PCA, but and maybe potentially don't have the full domain, exact domain pattern we would expect to see, but show really disproportionate kind of effect in the visuospatial domain, in addition to like more typical Alzheimer's disease. And so, yeah, here, David, I did make your key, sorry. But here again, we see right, the visuospatial domain is really hit and visual memory is pretty strongly hit. And then this middle patient, other cognitive domains are affected. And so another thing we noticed and people have noticed is that, and this is work we have done, Dennis, who probably isn't here because he's at the VA, really spearheaded this work, but it's known in the literature that patients who have earlier onset of sporadic Alzheimer's have much more atypical presentations of AD. This leads to delays in diagnosis. This means that they often have non-memory symptoms as their first complaint. And these earlier patients tend to encompass the really focal cortical presentations like PCA. But most studies are done in clinically diagnosed samples. And so it's not totally clear if this age-related difference is due to like the AD neuropathology itself and potentially something about its distribution or about other non-AD neuropathologies that Melanie mentioned, like Lewy pathology or late. And so with Dennis and David, we looked at a cohort of AD cases from our ADRC, particularly looking at how age of onset affected domain function neurocognitively and distribution of pathology. And so what we noticed is that executive function and visuospatial function were especially impaired in patients with earlier onset of disease, while memory and language were really not significantly different. When we looked at the pathology, we looked at particularly pathology in the middle frontal lobe and the hippocampus, because that's basically what we had available. We saw that the early onset patients really had much more pathology in the middle frontal lobe compared to the hippocampus. And the later onset patients tended to have much more hippocampal predominant pathology. And again, this is not 100% new. So Melissa Murray and Dennis Dixon also saw something kind of similar. But this is the first time that Dennis did a really kind of snazzy analysis with the help of Steve Edlund, and was able to show that really it is the density of the middle frontal neurofibrillary tangles that mediates this effect on executive function. And additionally, that this middle frontal to hippocampal tangle ratio couldn't account for problems in this cohort with visuospatial function. So although the cohort has right, the early onset cases have like very impaired visuospatial function, it wasn't simply explained by the number of tangles in the middle frontal cortex. So this leads us to what we've kind of roped Melanie and Allison into doing, and why I wanted to present this, which is that we're really interested in trying to figure out if there's disproportionate occipital tau in early onset cases and whether this mediates visuospatial deficits. And so using our ADRC, basically all the cases in our bank, we have about 40 early onset cases and about 15 pure PCA cases. And now we're going back and we're actually going to look at the visual cortex, at kind of higher order visual cortex, and sit down and look and count and figure out if the tau pathology in these regions actually mediates the clinical findings in these patients that maybe don't have full-blown PCA, but have a lot of visuospatial deficits. And this would be another way that potentially be another thing suggesting that early onset Alzheimer's and the pattern of tau deposition and maybe even the progression of the disease is different in earlier cases than late cases. And so we don't really know exactly, this would be descriptive, we wouldn't exactly know mechanism, but it would be the first time, if we see it, that it would be shown that early onset cases have visuospatial deficits that are really driven by their occipital tau pathology. So that was really why I wanted to make us basically look at these cases, think about this idea, and get going on this project. So hopefully in the next, year, we'll have a paper that will show disprove or disprove this hypothesis. And I think Dennis is probably not here, but we did want to say thanks to all of the people who worked on these projects. And Melanie and Alice and I are looking forward to getting started. And so we're happy to take any questions.